Assalamu alaikum, my name is Urva Hilal and my roll number is BP1650245. My group number is 38. The topic of my presentation over here is enteric nutrition for post-sternotomy patients. So let's get started. Adult enteric nutrition. Before going to our main topic, that is the case study, we should know what our case study is related to. What is our main topic? That is adult enteral nutrition. So let's see what is adult enteral nutrition. Enteral nutrition is using the gastrointestinal tract to supply nutrients. They can be accomplished with feeding by mouth or through a feeding tube. So there are two types of enteric nutrition that we can see by feeding by mouth, or second is the feeding tube. The enteral nutrition has much more advantages than a parenteral nutrition. What are those advantages? That it is more safe, effective, decreased risk of infection, decreased cost, prevents gut atrophy, and many others. Whereas, when we come to indications, enteral tube feeding is indicated in patients who cannot take adequate oral intake of food or nutrients to make them meet metabolic demands. Healthcare professionals commonly use enteral feeding in patients with dysphagia. Patients with dysphagia sometimes cannot meet their daily nutritional needs, even with modification of food texture or consistency. For enteral feeding to be successful, the GI tract should be accessible and functional. Inaccessible GI tract, malabsorption, severe GI losses might make enteral feeding a challenge. So, in that case, what would be our alternative? Parenteral feeding. So, as we were talking about the indications, so what are the indications over here? The indications for the following condition is coma patients on mechanical ventilation or with severe head injury. Then neuromuscular disorder affecting swallowing reflex. So what could be those neuromuscular disorders? It could be a Parkinson's disease, it could be multiple sclerosis or cerebrovascular accidents. Then we have severe anorexia from chemotherapy, HIV, sepsis, upper GI obstruction, esophageal stricture, or tumor. Condition associated with increased metabolic or nutritional demands, sepsis, cystic fibrosis, and burns. Mental illness like dementia. These were the indications that were for enteric nutrition. Now, as we've told you previously, if we cannot get the nutrition by the mouth, our alternative would be the feeding tube. The feeding tubes are very important in enteric nutrition. So let's see what are the type of feeding tubes. Types of the feeding tubes. There are several type of enteral feeding tubes. They are usually made of polyurethane or silicone. Feeding tube diameters are measured in French units. Each French unit is equivalent to 0.33 millimeter. Feeding tubes are usually denoted or classified by the site of placement. Now, here are different routes of the feeding tube, or we can say different types of feeding tube. As you can see in the picture over here, nasogastric tube. Nasogastric tube is over here. It is going from the nose, from the nasal cavity, then into the stomach. So, nasogastric tube. Then we have nasoduodenal tube. Nasoduodenal tube, you can see over here, it is going towards the duodenum. That is nasojejunal tube over here in the jejunum part of the small intestine. Then there is gastrostomy tube, jejunostomy tube, and gastrojejunal tube. You can easily see the routes of feeding over here in this diagram. So as we can see, the feeding tube is very important. So what is the next most important thing? We have the feeding tube, but next most important thing is enteric formula. And in enteric nutrition, enteric formula is very, very important. That what in and choosing enteric formula is also very much important. That how will give the patient the nutritions, by which route, or what are the nutrition that we are giving, what is the situation that the patient is in. According to that, the enteric formula is given. So what is an enteric formula? The enteric formula is used, which can be of several types. A great variety of enteric formula is available. It can become quite a challenge to decide on the most appropriate formula to describe for one's patients at all times. Various classification can be used, but ultimately the following categories are primarily for the essence. Over here, you can see in the flow chart, it's the interior formula classification. So we have gastrointestinal functions. It can be normal or it could be impaired. Impaired means something wrong with the organ, or we have a disease state or something like that. Okay, so when we have a normal one, it can be a disease specific formula or a polymeric formula. In a polymeric formula, we have different types of things like isotonicity, high protein, high energy, fiber content, and then there is modular components like carbs, proteins, lipids. Whereas in the disease specific formula for both normal and impaired, it depends upon different diseases like renal diseases, diabetes, low in specific electrolytes, respiratory, and immune modulating. Immune modulating is specific for the surgical procedures. Whereas in the impaired ones and semi-elemental, it's almost the same as the polymeric one, that is isotonic, high protein, high energy, but the difference is over here is fiber. In the polymeric normal one, we give fiber content, whereas in the semi-elemental one, the diet should be fiber free. Let's move on. Now, as we have talked previously about the indications of the enteric route, let's talk about the contraindications. Enteric nutrition is contraindicated in some special cases. That could be absolute contraindications or relative contraindications. Absolute contraindications include hemodynamic instability with poor end organ perfusion, enteral feeding in patient with bowel ischemia or necrosis can make a bad situation worse. Active GI bleeding, small or large bowel obstruction, paralytic ileus secondary to electrolyte abnormalities, peritonitis. Then we have relative contraindications. Relative contraindications include moderate to severe malabsorption, diverticular disease, fistula in the small bowel, and short bowel disease in the early stages. Now, finally, we are on the main topic. As we have covered the whole intro, that what is the adult enteral nutrition, or we can say the enteral nutrition, but over here we are more concerned about the adult part, not on the children, adult part. So, case study. What is a case study says? A case study says that there is some Mr. X, who is a 20-year-old male admitted to the ICU post-sternotomy for a single stab to the chest. He required intubation and ventilation for airway protection due to facial swelling secondary to venous occlusion. Esophageal injury was excluded. He has no previous medical history of note and was a healthy, fit individual according to information obtained from his family. Anthropometry on admission was an estimated weight of 63 kg. Height derived from ulnar length of 1.65 meter and a BMI of 23 kg per meter square. Biochemistry was essentially normal. On clinical examination, the patient was intubated and ventilated, but awake and able to respond. He was kept intubated due to severe face swelling. His abdomen was soft and unremarkable. Now, this was a case study. Now the question arises, how would we manage the enteric nutrition of the patient? Let's see. The first that we have to do is make the SOAP notes. Now, what are the SOAP notes? SOAP, SOAP. S is the subject, object, assessment, and plan. So what comes first? The subject. The subject includes the weight, that is 63 kg. Age, we have seen 20-year-old, gender male, BMI is 23 kilogram per meter square. And what is the history that we have seen? He had no previous medical history of the note and was a healthy and fit individual according to information obtained from his family. Now let's come to the objective. The objective is that the patient was admitted to ICU post-sternotomy for a single stab to the chest. On clinical examination, the patient was intubated and ventilated but awake and able to respond. He was kept intubated due to severe facial swelling. His abdomen was soft and unremarkable. Biochemistry was essentially normal. Then we come to assessment. What is our assessment? Due to intubation and ventilation, the patient required enteral nutrition. And by which rule we are giving that? We are giving it by nasogastric tube. Now as we have done SOA of the SOAP notes, the last part we have is the plan. What is our plan? What are we going to do when we have all of these? What are we going to do next? So what is recommended? It is recommended that standard polymeric formula be used when initiating enteral feeding in most patients. Polymeric formula is that's why I use because it's for the normal ones. It does not, it's a standard one, somewhat type. So then the nutritional requirement were calculated during the Aspen guidelines for ICU. These are the standard guidelines, standard clinical guidelines that are used to give different nutrients. So according to that, Aspen guidelines for ICU of 25 to 30 calorie per kg ton and 1.2 to 2 gram per kg protein. Actual body weight was used in the calculation, and that came out to be 1575 to 1890 calorie ton and 76 to 126 gram protein. Due to the facial swelling, a decision was made to reduce his total fluid volume, and his fluid volume was restricted to 1500 ml per day. Why did we do that? Because of the face swelling. If we increase the amount of fluid, it would not prevent the face from getting back to its shape. Instead of that, it would provoke it to get to more swell, and it can cause severe problems. So to avoid that, we are decreasing the total fluid volume. In order to meet his calculated requirements that we want in that reduced volume, his enteral feed prescription was changed on day 3 post admission. The script included 500 ml of polymeric enteral feed formula that provides 1.5 kcal per ml and 100 gram protein per liter combined with 1000 ml of a polymeric enteral feed formula that provided 1 kcal per ml and 38 gram protein per ml. As you can see above, we are not giving one polymeric feed formula, but we are combining two polymeric feed formulas together. The combination of the formula provided 1750 calorie ton and 800 gram protein in the allowed 1500 ml, meeting calculated requirements. Adding additional protein to standard polymeric feed has the advantage of meeting patient nutritional requirements without having to increase a total amount of feed delivered. So what is the advantage of that? Why are we doing that? Why are we combining the formulas? Why are we making it more concentrated? The advantage of higher concentration feeds are that less volume is required to meet individual patient need. That's what we want over here. We want less volume. We want less fluid volume. Therefore, patients with high nutritional requirement in combination with fluid restriction, as well as patient receiving enteral feeds over less than 24 hours, can benefit from using concentrated feeds. That's why we are giving the concentrated feed. It could be beneficial for them that we want to give total fluid in less quantity. Now, after day 3, we previously after day 3, we change, we give the combination. Now we are checking it again. As in the Enteric formula in the surgery, if we are giving the nutrition, we have to check again and again that if our Enteric formula, if the nutrition that we are giving is working in the right way. Either they're giving any disadvantage, either they're giving any harm to the patient, if there's something wrong with the body after the nutrition that we're giving to him. So to observe that, we have to look at the biochemical properties, biochemical tests, biochemical properties of the patients day after day from time to time. Okay, so now we are on day 4. On day 4 post administration, there was a slight improvement in his facial swelling, but the examination revealed that his upper airway was still swelled. So was considered for tracheostomy, before which the diet was stopped for a while. Before the tracheostomy, this diet was stopped. His enteral feed was recommended after the placement of the tracheostomy and was restarted at an increased rate of 84 ml per hour to compensate for the time that he was kept nil per OS. Means during the tracheostomy, before the tracheostomy, we stop the diet. So to come after the tracheostomy, when we are recontinuing the diet, at that we will increase the rate. That would compensate for the time that the patient did not take the nutrition. That would compensate that. Now we'll do the same thing till day 7. On day 7, we'll check it again. On day 7, post-admission, the patient was examined, and on seeing the positive results, he was continued on this prescription for another 3 days before he was safely extubated and transitioned to oral nutrition. Finally, the patient has been recovered to oral nutrition. So there are some important things to keep in mind that will come in our notes. When giving the concentrated feed, it should be kept in mind that it has a tendency to draw water into the GIT due to osmotic effect of the high concentration solution. This can result in osmotic diarrhea. Although we studied earlier that concentrated feed can be a very important thing, but it can have some side effects as well that we can see over here, that it can cause osmotic diarrhea. Next is if the patient resulted in having no stool pass for 1 to 2 days or constipation, the result is that what can we do if the patient is suffering from constipation or the stool is not passing for some days? We will give fiber in the diet. The fiber in the diet could be increased, which will eventually resolve the abdominal distension and will pass the stool easily. But there is something that is really important. As we studied earlier, that in the normal one and the impaired one. In the normal one, we can give the fiber content, but in the impaired one, the fiber content cannot be given. So it can be possible that if the patient has some disease, if the patient has some impaired organs, this fiber can become very, very dangerous. It could become lethal too for hypoglycemic patients. So fiber should be given to the patient after the complete description of the complete history of knowing the patient, what is the condition of the patient. The correct type of fiber should be used according to the patient's requirement. Just as I said, it should be ensured that the fiber content of feeds is increased gradually. It should not increase suddenly. It should be increased gradually so that the concentration of the fiber is not that much. It should not affect the patient body. And that the sufficient fluid is consumed with the fiber containing formula. This is important, that whenever if we are giving the fiber, the fluid is very important. There should be sufficient fluid with the fiber taking. That's all with my case. I rest my case over here. I completed the soap notes. In the end, I told you about what are the things that should be kept in mind by planning to give something to the patient by giving the nutrition to the patient. That would be the end of my case study, and that would be the end of my presentation too on the enteral nutrition, that is the adult enteral nutrition, on the adult enteral nutrition Adult enteral nutrition for post-sternotomy patient. Thank you.